Nice.
Thank you, Dr. Debashish, for having me in on this course, and good evening, everyone. I'll be speaking on anterior vitrectomy for cataract surgeons. I know we are running short of time, so I'll try to limit my presentation to what is absolutely necessary. Dr. Debashish, please feel free to stop me whenever you feel that I'm exceeding the time. So the best way to prevent vitreous loss is to prevent a posterior capsular rent from occurring and a vitreous loss from occurring. So you should be aware of the signs of an early signs of a posterior capsular rent, such as a pupillary snap, a sudden loss in depth of the anterior chamber, poor followability of your nuclear fragment, or a small spidering of the posterior capsule. And once you know that warning signs are there, you should do everything to prevent the occurrence of a posterior capsular rent. Once there is a vitreous loss, do not fail to identify the vitreous. Perform preservative-free triamcinolone acetonide particulate staining after OVD removal. And again, once you have completed the anterior vitrectomy, put in more TA and see to it that there is no vitreous strand. Here, this is Dr. Arup's video. He has found out that there is a small strand of vitreous here right at the section. He's sweeping the spatula to find out if it is there. He stains again, brings it to the pupillary area, and then it is cut and aspirated. So you make sure that you don't leave behind any vitreous in the anterior chamber. Do not use the phaco incision for vitrectomy. Use the paracentesis or a separate incision for a bimanual anterior vitrectomy. Here is a surgeon using the main incision. This should not be done, and there is also too much TA staining the vitreous. So these are the most frequently asked queries with respect to vitrectomy, the type of vitrectomy that you should do, whether it's a bimanual anterior limbal vitrectomy or to the pars plana approach, the gauge to use, the parameters, the sequence of cut rate, aspiration, bottle height, the direction of your cutting port, whether it's face up or face down, where to start the vitrectomy, how much vitreous to cut, the ideal OVD to use, and whether the anesthesia should be augmented. As I go through my talk, I'll try to cover everything briefly, highlighting the pertinent points. In most of our theaters, like how there is a emergency code, we also have a code V in a theater, which indicates to the scrub nurse as well as the circulating nurse that there has been a posterior capsular rent, and they should keep everything ready for the surgeon. As a posterior segment surgeon, listening to my patients, I know exactly, the patient knows exactly when the posterior capsular rent has occurred or when the nucleus drop has occurred. They tell you that, sir, madam, suddenly there was some commotion in the theater and the surgeon made a sound. So instead of doing this, you should have the emergency vitrectomy kit ready, and there should be a secret code between you and your scrub. There are different types of anterior vitrectomy. You can do a dry vitrectomy when you have a small amount of vitreous prolapsing into the anterior chamber, the bimanual automated limbal anterior vitrectomy, or the pars plana approach. Let us look at the settings for anterior vitrectomy. Use the maximum possible cutting rate that is available, the lowest vacuum. The cutter should be advanced or held stationary, and never pull back the cutter while you're cutting. Do not use low speed, high suction, and cut while pulling away. If you do not have a dual linear mode in your machine, this is the setting for the machine: irrigation, vitrectomy, followed by aspiration for anterior vitrectomy. And if you're removing the cortex at the end of the vitrectomy, it is irrigation, aspiration, and vitrectomy. Do not fail to understand the vitrectomy settings, and the bottle height must be balanced in such a way that you have just enough fluid flowing into the eye to keep the globe formed for you to work around the vitreous. These are the settings that I use, the same settings that I use for my posterior segment cases, the highest possible cut that is available on the machine. This is the Guida S3 VIP machine, and the lowest vacuum. This is a slide all of us are familiar with. The higher the cut rate, the less is the traction at the base, the vitreous base. So this is a patient who had undergone a scleral fixated IOL. On the table, everything was fine. And 1 week into the postoperative period, we noticed that there was vitreous in the anterior chamber. The vitreous is stained with triamcinolone acetonide, and the triamcinolone acetonide that is free is being blown out of the eye. You can see that there is vitreous right at the center. A bimanual anterior vitrectomy is performed. After compartmentalizing the vitreous, injecting a dispersive OVD into the anterior chamber, the vitreous is completely cut and aspirated. The cutting port facing upwards, because definitely the surgeon would like to see what he is cutting. And at the end of the procedure, again, a little more TA is put into the eye to see whether the vitrectomy is complete or not, and that completes the case. So there are certain misconceptions regarding limbal anterior vitrectomy, and this is why the limbal anterior vitrectomy fell into disrepute, and people started looking at the pars plana approach for anterior vitrectomy. It may cause aggravation of the posterior capsular rent and aggravate the vitreous lock. This is because the surgeon does the arachnic blunder of placing the cutting port too anteriorly, so that he'll be dragging more and more vitreous from the vitreous cavity to the front of the eye, or he uses a coaxial vitrectomy where there is infusion as well as cutting in the same port. And when all this fluid goes into the vitreous cavity, it will hydrate the vitreous and produce more vitreous to prolapse into the anterior chamber. Or if he is trying to do a vitrectomy, like I showed you previously, through the main wound. There is poor access to the subincisional vitreous, which is a wrong statement, because you have the ability to change your ports from one side to the other, and you can actually reach the subincisional vitreous. Potential trauma to the iris and anterior capsule may occur if you're not very careful, and it has a necessity to remove more vitreous than that is necessary, which is not the truth. If you're cutting the vitreous, you start cutting by putting the port just below the posterior capsular end in the anterior vitreous with the cutting port facing upwards, so that all the vitreous that is there in the anterior chamber is dragged back into its home. There are two exceptions where a pars plana vitrectomy is necessary. For example, like in this IC where we are dealing with zonular dialysis, where there is a knuckle of vitreous prolapsing, it would be better to cut it from the posterior segment, and vitreous is noticed after IOL implantation, in which situation also a pars plana anterior vitrectomy is necessary. So I'll come to the last part of my presentation, is should an anterior segment surgeon perform pars plana vitrectomy? There is a definite learning curve. You need mentoring, a wet lab experience, and also should be proficient in posterior segment techniques such as intraoperative indirect ophthalmoscopy, and should also know how to treat a peripheral retinal tear. The risks of retinal tear, retinal detachment, etc. is not very high. If you're going to use a trocar cannula system, beware that you require a very firm globe to introduce a trocar cannula system. And if the globe is not fully formed, you might get the pressure that you exert while inserting the trocar cannula system can cause the iris to prolapse and more vitreous to come out through the section. So the ideal way is to do a straight stab-in incision using the MVR knife. Do not attempt a pars plana anterior vitrectomy for the first time in a complicated case with an open globe and when the surgeon is under duress. There are certain advantages of a pars plana anterior vitrectomy where you bring home the vitreous back to its home. There's a definite endpoint for the vitrectomy. It limits the amount of vitrectomy that is necessary. And there is also better access to the cortex. So your infusion can be either limbal or pars plana. I would prefer a limbal infusion if you are going to do only a minimal anterior core vitrectomy. But in this situation, I'm using a pars plana infusion because I have to do a full-fledged vitrectomy. There's a drop nuclear matter in this patient. The sclerotomy that you give, would prefer a straight in stab sclerotomy, which you can suture at the end of the procedure. Do not go for the trocar cannula system in a freshly opened eye because you have to exert a lot of pressure. This is a patient who has had a vitreous loss at the time of surgery with dropped nucleus, and you can find out you can see the amount of force that has to be exerted to put the trocar cannula system. There's a new trocar that is open for the case, but even then so much pressure is necessary. And after completing the cutting port faces upwards, take care to preserve the capsula, what is remaining of the capsular bag, because you'll have to implant an IOL into the ciliary sulcus and continue with the vitrectomy. This is the end of the case. After putting in the IOL, the vitrectomy continues. So do not purposely violate the anterior or the posterior capsule. This is another such patient who had a dropped IOL. And you can see that we are using the remnants of the capsular bag for implanting positioning the IOL back into the ciliary sulcus. So during an anterior vitrectomy, limbal anterior vitrectomy or the pars plana vitrectomy, take care to preserve the capsular bag. Do not fail to provide aggressive antibiotic prophylaxis. A ruptured capsule increases the incidence of endophthalmitis. So these are the frequent queries which are answered. I hope I have covered what is necessary. I thank you very much for your patient hearing.